stroke?
Well, as you know, stroke is the number one cause of combined morbidity and mortality in the world today. And prior to 2015, all we had in acute stroke care was alteplase or TPA, which treated patients who presented to their institutions within 4.5 hours of their stroke. And if they qualified, they were able to get this drug. Usually between 5 to 7% of all stroke patients actually qualify and receive TPA nationally. So there was a huge role for something else to come in to provide better treatment for patients. In 2015, there were 5 clinical trials that actually demonstrated that if somebody comes in within 6 hours of the onset of their stroke and they happen to have a clot in the intracranial part of their internal carotid artery, middle cerebral artery, or anterior cerebral artery, someone like me could go through your groin or through your wrist and go all the way up into your head and pull it out. Those trials set the stage for a number of clinical trials to follow that has established endovascular treatment for large vessel occlusion stroke as the mainstay of therapy today. With that therapy, we've still only made a small dent into all patients who present with an acute ischemic stroke. So if you look at who is getting treated today with endovascular thrombectomy, it's only 10 to possibly 15% of all patients who present with stroke today. On top of that, you add 5 to 7% of patients who are receiving TPA, and you're still leaving between 75 to 80% of patients with no treatment. And that's where we see our work, which has been in the lab and now in patients, to serve as a potential to treat a significant number of patients who don't qualify for TPA or do not have a large vessel occlusion stroke. I think one of the things we have to think about when we're thinking about drug therapy in acute stroke, they really fall into 2 large buckets. One is neuroprotection and the other is thrombolysis or breaking up the clot, whether it's a large clot or even clot within the microcirculation of the brain, which is responsible for a considerable amount of morbidity in stroke today. And I think what we have to think about with these agents is not only their efficacy, but also their safety. And so our goal in developing new therapies for stroke is not to only have something that's efficacious, but also to develop a therapy that is safe. And the way we've accomplished that is we've actually developed a therapy that is a strong thrombolytic, and we've designed a second therapy that has the ability to turn the first drug off within 2 minutes, thereby providing a level of safety that does not exist today clinically. Our research focus and therapy focus right now is on von Willebrand's factor. Von Willebrand's factor has been identified as the target present in all patients who present with large vessel occlusion stroke and analysis of their clots. Furthermore, when we look at von Willebrand factor and we look at patients who have too much von Willebrand factor, it's something called thrombotic thrombocytopenic purpura. Patients who have these diseases present with either a heart attack or a stroke. If you look at the converse of that, where patients don't have enough von Willebrand factor, it's something called von Willebrand's disease. 80% of patients who have von Willebrand's disease have type 1. And those patients don't have a spontaneous bleeding diathesis, but they are protected from both heart attack and stroke. So it really sets the stage from both the genetic basis of disease and in the histopathology that we've seen in stroke today, that von Willebrand factor is an ideal target for stroke intervention. What we've developed at Basking Biosciences is a targeted therapy that to von Willebrand factor, and then we've designed a second molecule that actually turns off our active drug. What we've demonstrated in our preclinical studies is that it does a superior job of recanalizing the blood vessel in stroke models, and our phase 1 clinical trial data has demonstrated that there is strong target engagement, that it has very reliable nonlinear pharmacokinetics, and that when we looked at healthy volunteers who were enrolled in the trial and received BB31 or our von Willebrand factor inhibitor, that their point of care thrombosis testing demonstrated complete obliteration of thrombosis. We plan to be starting a phase 2 clinical trial that will begin enrolling patients in July of this year. We have established the sites that will serve as part A of that phase 2 clinical trial, and we look forward to testing the drug both in terms of safety and surrogate efficacy to serve as a game changer for patients who present with acute ischemic stroke.